Hello and welcome to Your Health in Your Hands. I'm Dr. David Ajibade with the Brain and Body Foundation. Now, over time, we've been having several requests from women, especially saying we want to know more about female health, things to do with hormones, menopause, PMS, those painful menstrual periods, and what can be done about them. And for a while I'd been looking, because quite frankly, I needed to find someone who was acquainted with how things are done in Nigeria, but also acquainted with how things should be done in, shall we say, more advanced settings. And so it's really been a pleasure, and I have to say that I'm so glad that we finally found someone who can really help in that direction. And it was Dr. Abayomi Salawu, who talked about rehabilitation, if you remember, about 2 weeks ago. And he did an excellent job. And this is one of his colleagues from medical school. I actually met him as a house officer, but he doesn't remember me, and I'm not sure I remember him either. But without further ado, let me introduce our guest today. We have Professor Alex Olawaiye, who is on today. Prof, welcome to the show.
Thank you very much.
All right, we appreciate you making it. Tell us a little bit about yourself, and then we shall talk about your profession.
Yes, thank you. So I was in the same class in medical school with my very good friend, Abayomi Salawu. And yes, he had contacted me and asked me to do this. I graduated from Ibadan, from UCH many years ago, and went to Britain, where I trained in OBGYN with the Royal College of Obstetricians and Gynecologists, and then subsequently moved to the United States. I did my residency in New York State, and then subsequently did my subspecialty training in oncology at the Harvard Medical School. I'm now based in Pittsburgh at the University of Pittsburgh School of Medicine, where I'm a professor of obstetrics, gynecology, and reproductive sciences. And my subspecialty is gynecologic oncology. So I take care of women with female type cancers. And it's really a pleasure to be on this show, and I'm hopeful that we can get through some very useful information today.
Absolutely. Well, we appreciate it as well. So that is interesting. Women with gynecological cancers, as we know, Nigerians and Black people in particular have this higher rate of several different kinds of cancers. So we're going to get into that some more. One of the things that we were talking about before the show started was some of these issues with hormonal profiles through the years. So let's talk about menopause. We know that a lot of things happen after the age of 45, 50, when menopause is setting in or over, and especially female cancers. Can you take us through some of this and why it happens around that age? What is it? Was it the hormones? Is it activity levels? Can you just help us understand that a little bit more?
Yes, to actually delve into that very well, let's talk about the physiology of reproduction. So most women, they get to menarche, which is they start their periods about the age of 11 to 13, somewhere around there. And initially, the menstrual cycle is a little bit irregular, but for most people, after a few years, it becomes very regular. And all of that is normal. And right up to about age 40, 42, 43, they remain fertile, okay? Right. And for most of those years, their periods are regular if they don't have problems, okay? There are all sorts of problems that can cause periods to be irregular. We're not going to get into that. Around about age 45, for most people, the number of eggs in the ovaries, because that's really what drives the menstrual cycle, is a very well orchestrated control between centers in the brain and the ovary of the woman. And the signal is coordinated honestly speaking, the uterus, where the period itself comes from, is an end response organ. What controls it is ovary and brain. And the way it happens is the brain sends signals to the ovaries to release hormones. And in the course of doing that, a certain number of eggs are recruited into the cycle, usually about 5. And one of them we ovulate in most of the ovular cycles. And then if the woman doesn't get pregnant, a period would occur. That very well, knitted process begins to change about age 45. And that change includes changes in the length of the cycle. For the average woman, they have a cycle every 28 days. So initially what would happen is the cycle length begins to get longer. So the woman is now having a period maybe every 33 days, maybe every 34. It becomes somewhat less regular, and mostly the length increases. And this happens for about 4 years. And around about age 51 to 51 and a half, the women would have what we call FMP, final menstrual period. And it is at this point that we say they are menopausal. But menopause itself is a clinical diagnosis because of what I just described. If the woman says, I had a period 2 months ago, am I menopausal now? Well, you can't tell, because it may just be that irregularity. If you tell her that she's menopausal, she can come back next month and have a period. It's just it's irregular. So
or get pregnant.
We don't declare menopause until 12 months after the last period. That is when we're sure. So that is generally what happens in most women. That process is normal biology. It's normal, it's natural. That is what the body of a lady is programmed to do as they get to that age. This process, unfortunately, can occur before age 40 in some women, and the reasons are many. But in that situation, we call it primary ovarian insufficiency, because the ovary is stopping to work earlier. Some, it would occur, it will start around 40 to 45, we call that early menopause. And for those who start after 45, that is considered regular or expected time of climacteric, which is the changes that lead to menopause.
Is early menopause, could that be a problem health-wise, or late menopause? Because I'm thinking dementia now, I'm thinking about brain conditions. We know in some cases, researchers see people having an early menopause as a risk factor to dementia, because the brain is exposed to lower levels of estrogen for a longer period of time. I don't know what your thoughts are about that in other cases as well.
Okay, so can early menopause be a problem? Yes, it is a problem. Because we know that women who go into early menopause are at a higher risk of osteopenia or osteoporosis, which is brittle bone disease. Women who go into early menopause are at risk of cardiovascular heart disease. If you compare them to women who go through menopause at the usual time, they are at a higher risk. So these two, which are consequences of them losing their hormonal status early, definitely represent higher risk. Now, the issue with dementia, it's a very interesting one. In one of the largest studies called the WHI study, Women Health Initiative study, published in 2002, it was a study conducted in North America, and in that study, the issue of dementia came up. And it is true that, you begin to see dementia after the age of menopause in many women, right? And the risk seems to be higher for women than men. So that is epidemiologically pointing to the fact that the estrogen level may have something to do with it. But just for you to know, there is no evidence that if you were to treat women, give them estrogen replacement, that will mitigate their risk of dementia. So that risk, we think, is related to menopause, is related to the hormonal changes, but it does not appear to be preventable by giving them estrogen or hormone replacement.
Makes sense. Makes sense. All right. So we've talked about what happens during menopause. Now let's delve more into your specific field of expertise, which is cancers. How are these hormonal profiles and changes around menopause? How does that relate to cancers, female cancers?
First of all, let's talk about the symptoms of menopause, because that is something that a lot of women would want to hear.
Right.
When women are going, actually from those years, running up to 4 or 5 years, running up to menopause, starting from about age 45, 46, they begin to have these intermittent heat waves affecting their head and neck area. We call it hot flashes or hot flushes. That tends to be more troublesome at night. And as a result, it can lead to sleep disturbance. And it is the most important symptom of menopause. Now, in addition to that, women also have increased risk of depression around this time, and especially immediately after menopause. And then there is something called vulvovaginal atrophy, which is atrophy or shrinkage of vagina and the vulva area. And the reason for this is because estrogen is very closely related to sustaining blood flow to the vagina and the vulva. And the blood flow is significantly reduced once that hormonal change occurs. So that area of the female private becomes less estrogenized, as we call it, which is indicated by the reduced blood flow, in turn causing dryness, discomfort, which can cause all sorts of problems with sexual intercourse. This is very treatable and is very responsive to vaginal estrogen creams for women that are affected. For the hot flashes, for that happens in about 40% of women or less. For some reason, why some women would have it that bad, and some are totally asymptomatic of the hot flashes, we have no idea. It varies from regions of the world. It's as low as 30% in some countries and as high as 50% in some countries. But it differs from woman to woman. We do think, and this is very important to emphasize, that for those people with troublesome symptoms, they actually can benefit from hormone replacement therapy. And the risks of taking hormone replacement therapy, which we're not going to get into, the absolute risk for these women between the age of 50 and 60 is very low. And frankly speaking, in reproductive biology, we believe that the risk is less than the benefit. So the benefits outweigh the risk. And therefore, women that are experiencing very bad menopausal symptoms should not be deprived of hormone replacement therapy just because of the risks, because the risks are low. Right. Now, this cancer is very interesting because this is not limited to women. Almost most cancers, although we do have childhood cancers, but most cancers actually track age. So age is kind of the number one thing that will put any human being at risk of cancer. Now, that risk is very, dependent on many things. It depends on the who you are born to, your genetic makeup. Some of us, may have been born into families where there is excessive cancer risk because there are some genetic syndromes or genetic mutations that are being carried in those families. But overall, age is very important in cancer development. For instance, talking about women's cancers, the median age of a woman developing ovarian cancer is about 62, 63. The median age of a woman developing uterine cancer of the uterus is about 62, 63. Breast cancer is hardly ever seen before the age of 50. Mm-hmm. And so it's not perhaps clear that the menopause is what is putting the woman at the risk of cancer. Menopause happens after the age of 50, and after the age of 50 is when cancer develops. That is, in my mind, two events that tend to occur together in the same space. They are not necessarily related to each other. We don't have any evidence that the menopause change in itself puts the woman at the risk of any cancer. Now, what is important is the most common of the genital tract cancers. Okay, breast cancer is also a gynecologic cancer, and that's the most common cancer worldwide. But in the female genital tract, the most common cancer is cancer of the uterus. And cancer of the uterus is very, very interesting because almost always, about at least 90% of the time, it will be associated at the beginning with bleeding. Okay? So the one message that I want to make sure that people know today, especially those who are non-doctors, once a woman goes through menopause, okay, there is no good reason, none, to bleed. So when people bleed after menopause and they say, oh yeah, my period returned, after all, I'm a woman. No, your period has not returned. If you bleed, listen carefully, 1000%, you must see a doctor and they must sample that uterus, okay? Because of the fact that 90% of uterine cancers are associated with bleeding at the beginning, if the woman is investigated expediently, most of them will capture them in stage 1. When they wait, the cancer goes to higher stages. And by the way, the question you ask about Black women is very, very important. This is something that we're still studying. There are 2 types of uterine cancer. The low grade, the one that is not likely to be advanced, or diagnosis is not likely to behave aggressively, is likely to be cured by simple surgery, and the woman is likely to be able to move on with her life. Then there is we call them type 1. There is the type 2, generally speaking, they are high grade cancers. They're very dangerous. And, for the doctors, this includes papillary serous cancer, clear cell cancer, carcinosarcoma, dedifferentiated cancers. These are extremely dangerous cancers. And for whatever reason, these are disproportionately represented amongst Black women. And they are the ones that is so important to catch as early as possible, because their propensity to progress or to recur and, of course, to kill the woman very high. So that's as far as that is concerned. The breast cancer is very, very common, But just for you to know, over 90% of breast cancers are also diagnosed in stage 1 in advanced countries. Why? Because they have programs like mammogram, which is recommended that people should have shortly after age 40, even if it's going to be once every 2 years until they turn 50. And after 50, the US Preventive Services Task Force, which is the main body trying to prevent cancer in the United States, recommends that women should have it every year. So I know that this is not readily available in many developing countries, including our country, Nigeria. But for those who have access to it, please, you should have mammogram at least once every 2 years at the minimum, and after age 50, once a year if the person can afford it. In the absence of that, other things that women do, they're less effective. It includes self-breast examination, and so on and so forth, and looking carefully when they go to shower at the anatomy of the breast, and if anything looks like it's changing, whether it's color, whether it's size, that they should immediately seek help.
That's so important. I was hoping we could get into that as well. So two main things that I've picked out. One is, if there's bleeding after menopause, you got to get a doctor. And two is, if you do the mammograms every year, if you can, and if not, just be very, very aware, hyper aware of your breast contours and your breast consistencies. Is there anything else that people or women can do to prevent cancers of the urogenital tract?
Yes, I mean, so let's start from below. So around the vulva, it's a good idea, even if it's once a month, to use a mirror to look at what the vulva looks like. And that's an advice that we give to a lot of people who I have taken care of, who have precancer lesions in that area. And, women will often tell you that, oh, that would be weird. I'm not used to, yeah, it will be weird initially, but that whatever you think of what it looks like, that is you, that's your body. And what is important is to note what it looks like. And so if anything changes, you see a discoloration, you see a white structure that you have not seen before, that needs to be a reason to call the doctor and have a biopsy. Because if it is something bad like cancer, it's likely that it's early because it's just appearing, it's new. And then they can take care of it, hopefully with very minimally invasive or not too big surgery, okay? Now, if you go higher than that, let's go to the cervix. That is actually, cancer of the cervix is the most common cancer in women worldwide. Over 500,000 women are diagnosed with cervical cancer every year. There are two things I want to say about that. Number one is the vaccine. We have the anti-HPV vaccine. We have the triple vaccine. We have the vaccine with about 9 or 10 strains in it. I don't think it matters which one people can get. Every girl who is between the age of 9 and 12 is advised to get vaccinated, i.e. we advise their parents to vaccinate them. And this advice continues till, in fact, any age before 45. If you have not been vaccinated and you have access to the vaccine, please get it, because you might just be able to prevent something like cervical cancer. And if anybody thinks that that is, just an advice that people are given, no, we have direct evidence from many, many studies about how effective the vaccines are. And we also have direct epidemiology evidence from Australia, where they have practically stamped out cervical cancer because more than 80% of their population are vaccinated at the appropriate age. Yeah, the standard age is somewhere between age 9 and 26, but we're now extending the advice and say, look, if you can get it at any age up to 45. Now, that is, and for a country like Nigeria, this, in my mind, is so critical because the treatment of cervical cancer is very expensive, and we don't have the resources that are needed to give those treatments in an expedient fashion. We don't have enough radiation machines. Surgery is very difficult to come by, and in certain settings may even not be safe. And so preventing it is, in my mind, is cheaper and it's better for the country, because this is a cancer that takes women at the prime of life. Okay, most cervical cancer patients, unlike the other cancers in women that we talked about, are around age 40 to 44 when the women are their prime. It's horrible. Now, the next thing after vaccine is pap smear, which is advised to be done if you're able to get HPV screening with it. It actually, if it's negative, it is safe to wait for as long as 5 years before you repeat it. So pap smear with HPV screening, absolutely life-saving. And if it's abnormal, the treatment of abnormal means if they detect precancer in the screening, the treatment is very, very simple. First, we do colposcopy. We use a lens to look at the cervix and paint it with acetic acid. It will highlight the area that is abnormal. We take a biopsy. The biopsy will tell us what is, usually it's a precancer lesion. And with a simple procedure like something called loop electrosurgical excision procedure, or lip conization, as people refer to it as, or even cryosurgery, using liquid nitrogen to burn the lesion off. That can prevent the life of, that can prevent anything bad happening to the woman by preventing cancer. So pap smear is so critical. We have already talked about endometrial cancer, and that one, it's you bleed after menopause, or before menopause, you have consistently abnormal bleeding. You should seek help from the doctor. There is no screening for ovarian cancer, but all women are advised to have a pelvic exam by a gynecologist once a year, at least. And that exam can detect things like mass and swelling in the pelvis. And sometimes that can be cancer that the doctor is feeling, and it could be very early. It could just be a swelling on the ovary that the cancer is confined to that, and the surgery to take care of that is simple and can be curative.
Makes sense. Well, that is a lot to take home, a lot to take home. Thank you so much, Prof. This is very, very important. I know you have to leave soon, and we're coming to the end of our episode here, but we definitely need to have you come back and elaborate on a few other things that we've talked about today. But we really, really appreciate your time today, Prof. Thank you so much.
The pleasure is mine. It's nice talking to you.
Nice talking to you too. And folks, thank you so much for joining us. Remember, these videos are archived on our website and on the NTA YouTube site as well. If you have any more questions, if you have topics that you want us to address, please send them in. We'll be sure to consider them and look for the appropriate people to work on them as we did today. So please, our goal is to educate Nigerians on how to take control of their health. And by giving us this feedback, we'll be able to help. We'll be able to accomplish that even more. So thank you again for joining us. God bless. See you next week. Take care. Bye.
Bye-bye.